Committee. And I am co-chair for the Sacramento County Opioid Coalition Executive Committee. My other co-chair, Janet DeMonchel, Sac State Pharmacist, is also on the call. And we want to welcome you all to our third coalition meeting for this year. I'd also like to just briefly thank the other members of our executive committee for helping plan today's meeting. Lori Miller, Ranjit Diwali, Ashley Zaru, Ed Juke, Lori Slothtower, Mark Ott, Jamin Martinez, Dr. Melody Law, Dr. Olivia Kasiri, Sam Motz, and finally, Sean Vassar. Can you guys hear that beeping, or is that just me? Do you hear that too? Gosh, I hope not, because it's really annoying. Okay. I guess that's every time somebody comes in the meeting. All right, so before we get started, we're going to do some community updates. And the first one is that we want to let you all know that we are putting on an opioid summit in October. And it is for educators and public health professionals. Lauren, would you mind throwing the registration for that summit in the chat, please? So she'll put the link up there. But this summit's really for anybody. So it's going to be on Tuesday, October 11th from 8:30 to 4 p.m. And it will be in person, yay, hopefully things are still going okay, at Sac State University's ballroom. And really it's for anybody, like I said, educators, school nurses, counselors, mental health clinicians, substance use clinicians, coaches, parents, and really anybody that is interested in working with our youth and making sure that they are staying safe when it comes to opioids. So you're going to learn a little bit about the state of the opioid epidemic, a lot about data. We'll get intelligence briefings by federal, state, and local law enforcement. We'll have Sherry Egeland on, who is wonderful, and she'll talk about the likelihood of youth misuse and other controlled substances and what you can do to be on the lookout. And a lot of other things. We'll also have some physicians on as well to talk about medication-assisted treatment and safe prescribing as well. So I hope that you all can make it. It is completely free, and feel free to share the link that Lauren put in the chat with others that you think might be interested in attending this. So I think we have a lot of room for people and have about 150 people signed up so far. All right, I'm gonna go ahead and throw it over to, hi Lori, I'm gonna go ahead and throw it over to you now if you'd like to give any updates for your department.
Sure. Good afternoon, everyone. My name is Lori Miller, and I'm the Division Manager over the Substance Use Prevention and Treatment Unit of Behavioral Health Services with Sacramento County. So I'd like to go ahead and share my screen if I have permissions to do that, Lauren. Let me know if you all can see my screen here.
Yes, looks good.
Thank you. Okay, so I'd like to start this afternoon with some recent coroner's data. Here in Sacramento County, we continue to see a rise in fentanyl poisonings and overdose, a huge concern to all of us. And I just kind of want to put this in perspective for you with regard to the data. So from January 1 of 2020 to July 12th of 2022, fentanyl-involved deaths were more than homicide deaths with a gun. So this is a huge issue in Sacramento and an area that we really focus on in the Substance Use Prevention and Treatment Unit, but also through this coalition effort in other departments across the county, understand and want to make sure that we're targeting this and trying to reduce these deaths here in Sacramento. So moving on, so for the first 7 months, January to July of 2022, we've already seen 50 fentanyl-involved deaths. And compared to last year, we had a total of about 116 deaths. So I'm thinking that we're probably going to see more deaths than that this year. What's different about this particular slide is that the age demographic is a little bit different than we were seeing last year. We were seeing more of the teenage, early college age, up to 30-year-olds, the primary individuals that suffered death. This particular slide shows, if you can see it, I know that the numbers are really small, but We're seeing 30 to 40-year-olds now, where the numbers have increased already in the first 7 months of the year. So interesting kind of shift in the data. Moving on, this slide kind of shows you from January to July, again, 50 fentanyl-related deaths, which is more than homicide with a gun. And then it gives you some other deaths here. Meth-involved deaths are pretty high as well at 68. So something we continue to target here in Sacramento County is stimulants as well. So any questions on the data, you can certainly ask me or any of the information that I'm going to provide to you this afternoon. Next update is, this is the Fentanyl Poisoning Awareness Day. This is the very first of honoring this day, August 24th of this year. And so on August 21st, wear red for change to show your support for the families of those we have lost to fentanyl poisonings and your desire to invoke positive change for all those who have been affected and impacted. Next update is International Overdose Awareness Day that's also coming up in August, so August 31st. So I encourage all of you to honor this day, any of those individuals and family members that have had somebody pass away due to overdose. Then coming up in September, we have our National Recovery Month that we celebrate through the entire month, but a special event that we have annually is our annual Recovery Happens event, and this is the 30th annual year for this event. It will be held at the west steps of the state capitol. Lots of different things happening that day. We have a pancake breakfast. We usually have a recovery walk, some resource tables, some presentations by local and state leaders. So we encourage all of you to come out and support us in that effort. And again, this is to increase awareness around the understanding of both mental health and substance use disorders and celebrate those individuals in recovery and those family members who have supported those individuals. Next, I want to give an update on our countywide Naloxone or Narcan distribution project. So our County Board of Supervisors approved for my unit, Substance Use Prevention and Treatment, to be able to have available Narcan at all of our public-facing lobbies throughout Sacramento. So all of our departments are going to be involved with this effort that we have, this campaign effort throughout the county, and be able to offer this to both staff and clients coming and seeking services. We do have a how to order Narcan flyer if you're an organization out there and not associated with one of the public-facing lobbies that we will be delivering to. There's a way that you can order that for yourself and for your organization, and we'll put that flyer in the chat for you. In addition, our Opioid Coalition team members and our substance use prevention and treatment team members developed a brand new Narcan and fentanyl flyer that talks about how to administer Narcan, some information about fentanyl and other great resource information on there. So we'll throw that in the chat for you as well. And we continue our efforts, our partnerships with the Sacramento County District Attorney's Office. So the Department of Health Services, we continue to partner in this effort. Our next phase of our campaign is looking at education and awareness within our schools. And so lots of different activities coming up around that. Any information that you all want to obtain, you can find it on the onepillcankill.sac.com website, as well as our DEA campaign that also focuses on the One Pill Can Kill motto. And we also have some information around school curriculum, lots of great resources and newsletter on the Song for Charlie website as well. An upcoming event that we have on August 27th is our very first in-person town hall. We've had a couple of town hall meetings that were live streamed on YouTube over the course of the last 6 months, but this will be our very first one as we enter into the schools and really want to educate students and families around this issue in our community. So the first one will happen at Pleasant Grove High School, and this will be facilitated by an organization called Arrive Alive, and we hope to hit 3,000 students with that first event. And this is just a sample of a resource card that will be distributed at that event, along with Narcan and other resources that we will have available to students and families during that event. But that's all I have. One more thing. Some of you may have heard about this. Candy fentanyl has come to our attention here in Sacramento County. So sadly, we're seeing this kind of in this form. And this came to us from our partners in Monterey County. So if you guys are seeing this out there, please share with our departments so that we all can kind of be aware if it's coming here to Sacramento County. I have not heard of that, so maybe law enforcement partners in this coalition maybe can weigh in on this. I haven't heard about it here in our county, but certainly we're getting concerns from other counties around this. And that's all I have. So thank you, Lindsay. So if anybody has any questions, feel free to reach out to me via the chat or my email, Miller, LORI @saccounty.net. Thank you.
Awesome. Thank you, Lori. Appreciate that. And also just want to let everybody know in the coalition that our AmeriCorps Vista, Lauren Werner, who's on the call and kind of in the background with her strings, pulling her strings. She actually does Narcan trainings all throughout the community, online or in person. And we do have Narcan kits available that we have and some more from Sac County as well, along with some fentanyl test strips. And she'll go through and do the whole demo. Also, we've had quite a bit of success in getting in with some of the school districts and putting Narcan in the schools. I believe Elk Grove. Yes, Lauren? Yes. Yeah. Okay. And Sac City have both applied for all of their high schools and junior highs to have Narcan available on campus. So we're continuing with those efforts, just an FYI for everybody. One thing I forgot to mention in regards to our opioid summit, and I apologize, we do have a need for volunteers to help us out at the summit. If anybody on is willing and able, please email Lauren. Lauren, throw your email in the chat for me, please. We will absolutely take you up on your offer to help. Also, we have space for organizations to have a table at the event. We'll have space for at least 10 tables. So if your organization would like to be there, with a representative and maybe some informational items on your table, please let us know. It's free. We're not charging for it. Just want to get more information out into the community. Okay. Can everybody mute if you're not speaking, please? Thank you. Okay, all right, so let's get into the meat of today's discussion. So before I introduce our speaker for today, I wanted to let you all know that we're actually the Opioid Coalition and the Sacramento County Medical Society. We are working with Sacramento County's Substance Use Prevention and Treatment Department to promote medication-assisted treatment for prenatal and postpartum women in our county. And we are, among other things, doing at least 3 different types of webinars throughout the county. So we are presenting these at grand rounds at all of the hospitals, but we're also trying to get into some of the other departments, if you will, to present this information. So you're actually going to hear one of the webinars today. But a couple of the other ones that we have available are about using self-reflection as a tool for improving patient health outcomes. And we also have another one available on addiction pharmacology. So I'll actually throw my email here in the chat. If you have an organization that might be interested in us putting on these webinars, let me know. They're completely free and there are continuing education credits available with these webinars. So, with that in mind, this session is actually available for continuing medical education credits. Please email Lauren at the end of today's seminar, and she'll again put her email in the chat, and you'll receive a survey evaluation. After you fill that out, you will receive your credit or certificate. All right, so we are going to hear from Dr. Elizabeth Morrison with EM Consulting. So Dr. Morrison has over 25 years of progressive experience in working for and with healthcare entities to support cultural change toward whole person health through highly effective leadership, collaboration, consultation, and provision of practical learning and development programs and resources. She's also the CEO and principal consultant of E. Morrison Consulting, which oversees multiple large-scale initiatives. Finally, she actually has 25 years of experience as a practicing therapist and addictions professional, utilizing practice-based experience in integrated settings. So Dr. Morrison, welcome. We're so happy to have you with us today.
Oh, thank you so much, Lindsay. I'm so glad you're done with that introduction. It's so lame to listen to yourself be introduced. So I was trying not to listen. That's why I was typing in the chat. I just typed my email in the chat, which is at the end too. But I think yes, I have this workshop today that I want to engage with all of you. Maybe more importantly, though, I would love to talk with people or sort of have an ongoing dialogue, or I think I just want to feel like there's like a porousness there. I'm just going to say a couple things about myself that were not in there that I feel like, I don't know, might matter to all of you who are doing this work right up here. I'm pointing up here, up in Sacramento County, because I'm in Modesto, so I'm in Stanislaus County, just south of you. I'm from Alaska, but I have been here in the Central Valley for 16 years now, so it is definitely home. And I did have temperature shock when I got here, there's no doubt, but now I love the warm and could never go back to Alaska. But most of my time, before I started my own business, most of my time was in an FQHC right here in the Central Valley in San Joaquin and Stanislaus and Merced County, where I was the director of behavioral health and where we integrated behavioral health and substance use disorder treatment, including MAT. So that is really all my work now in consulting is also with safety net organizations. And as I'm looking at your names and some of the names I recognize and some of the organizations on the list I recognize. And so I just, I think I want to say I'm with you. It's a really hard time. It's a really hard time right now in social and healthcare. And I think most of us are dealing with really high levels of staff shortages. And I was just imagining like you coming to this meeting today and like what your Monday looked like and this meeting in the middle of it. I still see patients. I'm the staff therapist at my FQ here still. So I get the sort of staff perspective, but I also have just spent a lot of years as a clinician not going pee when I had to go pee and never eating lunch because there was no time. So I feel like I have I don't know, I just feel, I admire and respect and feel for what the level of busyness and intensity that it feels right now in social services. So I'm going to talk about motivational interviewing today. And I know that many of you have this, use these skills. In fact, if you are one of those people who may, for whatever reason, not really have heard of motivational interviewing, I can promise you're still using the skills. It's one of the nice things about motivational interviewing. It's like the skills are very kind of human, and as helping professionals and leaders and supervisors, we all kind of come by these things pretty naturally. So if you leave here today and kind of and the outcome is for you patting yourself on the back, like, man, I'm sort of kicking butt on this. Like, I'm doing a great job with evidence-based communication with patients, clients, my family. Then that's the people you supervise. That's actually a super great outcome. I would love for that to be the case. I'm going to focus a little bit more specifically on substance use disorders, of course. It's what, you all have your eye on here. And there are a few places in here where I certainly stop and ask your thoughts. But I really also would love it if you wanted to use the chat. Because I have it open and I'm always watching it. And it's like one of the downsides of Zoom is I don't get to sort of be there and feel you and look at your faces when it looks like you have something to say. So please feel free to chat in. If I miss it, Lindsay will catch it and tell me and read it out. I also wanted us to break out into pairs, no role play, totally not for people who might be introverts and are like, oh my God, I hope she talks the whole time. I know that doesn't sound good. And for extroverts, you're probably like, thank God she's not going to talk at us the whole time. But it is kind of a low risk activity. If you really, really would rather not pair up with someone and just to talk to them, if you can just text Lindsay privately And that way we'll leave you out of that when it's time, because I don't want to push someone, if you don't want to do that. But it is just pairing up so you can talk more in depth to one of your colleagues. So just want to say that that's all it is. Okay, I'm going to go ahead and share my screen. And let me just ask if people can just in the chat right now, if you can just say, like, on a scale of 1 to 5, as 5 is like you're an expert in motivational interviewing and it's totally okay to say you're an expert. And 1 is like you're not 100% sure what it is. Can you just like type in a number so I have a sense of where people are at? Yeah, thank you. I saw 2 that came right up. Oh, great waterfall for me to get a sense. Barbara, all right. I'd love feedback from you after this. Yeah, so there's a pretty good variation. I see a lot of people between at 3s and 4s, which is amazing, and there's a good reason for that. MI started in the substance use disorder field. That's where it came from. Oh, Barbara, that's funny. Barbara typed a 5, so I was like, oh, another, someone who like knows they're an expert, but she thought it was a scale 1 to 10. So, yeah, Janet's a 6. So. This is really helpful. I should have done a scale 1 to 10. It's what we use for pain. It's like more normal for us to do that, but I really appreciate it. And one of the things I sort of went in assuming was that most people have a pretty good sense of MI and are, like I said, are using it pretty consistently. Thanks, Janet, a 3. So I did sort of focus on like these very specific aspects that I think are, I don't know, really rich, really interesting. They're things in MI that I practice. Like Lindsay said, I have a doctorate in psychology and I'm an LCSW. I also have a master's in addictions counseling and worked for many, many years solely in the addiction treatment field. So I feel like I am practicing MI all the time, often with my kids, to be honest, which I'm going to talk about later. In fact, I have a colleague who often says, you should call your workshops on motivational interviewing how to get your spouse to do what you want them to do. And you would get like a ton of people who came because it is applicable. This really these are my kids. That's my mom up there. That's her boyfriend, who she insists I call her gentleman friend because they're 85. Also, if you get your mom an iPhone when she's 82, you too may have the horror of her getting on a dating website and sharing all the details with you, because that is what happened here. But thank God she was not on that very long and she met John, who's really nice. But I'm going to talk about my mom a little bit later because she's a really good example of someone who has a lot of empathy in their heart, but not really poor skills at communicating it. But really that is just to say, like, as I'm talking to you all today, yes, our patients and our clients and the people we're serving, and, yes, to the people that we supervise. And I would just say to, keep in mind how we use this in our daily lives with friends and family as well. So there's a lot of definitions of motivational interviewing, and I really want to highlight this piece that it is an empathy-based approach. I'm going to talk a little bit about the evidence, but it is an empathy-based approach. And there's been some movements in different parts of the field where sometimes like you'll see an MI worksheet that like tells a patient to like check something they want to do, and it feels like it's kind of forcing someone to check something. And I would say that isn't necessarily MI. Like the spirit is very squarely in the empathic collaboration space. Yes, Tina, it is super similar to human-centered design principles and human and person-centered counseling as well. I did just want to make an acknowledgement. Those of you who were 3s and 4s know that motivational interviewing, the term itself, which is kind of weird. I remember telling like a counselor who worked with me, like, I wonder how you'd feel getting some more training in motivational interviewing. And he said to me, I don't really like that Tony Robbins stuff, who's a motivational speaker, so it's a super weird name. But I just wanted to acknowledge that these 2 guys who invented it, Australian and British, they're old white guys. And motivational interviewing really built on the work by Carl Rogers, who's a dead white guy. And I think I just want to I just don't want to do any workshops anymore where I'm not acknowledging, that. The good thing about MI, which I am going to talk about, is the research is very squarely spread in every race and ethnicity and to the LGBTQ community. Like, there's been a lot of rigorous research to show how it works in different populations. And I want to acknowledge where it came from because it's a limited perspective, and the very early research on MI for sure included lots of bias since it was, done by very often white men. This is kind of like back to the human-centered design principles and person-centered counseling. This is like, for me, the kind of magic of MI, which is when we want to get people to do stuff because we know it would be better for them, whether it's like our clients or whether it's our kids, there's this feeling of wanting to push them, of wanting to like, come on, get motivated. And MI, the philosophy is super clear that it's really like the idea is we assume no matter what someone in front of us looks like, no matter if they look like they are in the most denial ever, we assume that every human wants to do what is best for them. Every human has motivation in this direction. And our job is really to sort of wake it up, to amplify it, to grow it, to water it. Like, that's really our job. So another way of saying that is anything that you want to say to your patient or your client, you're really trying to see if you can get them to say that to you. You don't want to say that to them. I'm just going to talk about the research here briefly, and then I'm going to talk next about the research on empathy in particular. But what I want to say is I have a hyperlink at the end of this slide deck, and I will share the slide deck, of course, with Lindsay to share all with you. There's a hyperlink to all of the research that I'm citing here and much, much more. And I have an annotated bibliography that's divided up by subject matter for MI. And the reason I do that is just because it's easy to like look through studies that you're interested in. And so it's all there. So the most important thing I want to say about the research about MI is it has about the same amount of research showing its effectiveness as there is research for statin drugs, and they're helping with blood pressure management. So for a communication approach, MI has incredible research. It almost looks like the kind of research you would see on a medicine. Now at this time, it's been studied on almost every race and ethnicity. The standout to that was the API population, but in the last 10 years, we've seen kind of an explosion of research in that area. It's been shown to be effective across cultures and ethnicities. And it's, I started in the substance use field. That's where it came from. That's what we're talking about today, because that's the field that you just want to shake people. For those of us who have people with addictions in your family, you just, it's like, why are you doing this? It's like, it is the condition that we feel like we want to like tell people what to do or like shout at them or be like, don't you see? And none of that works, which is why MI came out of the substance use disorder field. But really now, if you Google MI, it's like the first 200,000 hits are about diabetes, about all chronic disease, public health. Right now, vaccine hesitancy. MI has been shown to be effective with vaccine hesitancy long before the pandemic because they studied it with parents and childhood immunization. So anything you can think of that involves a behavior change has probably been studied with MI. And substance use disorders, because that's where it started, is the most heavily researched. So like I said, all races, all ethnicities, inpatient, outpatient, primary care, all different substances, polysubstances, OUD in particular, nicotine, like anything you can think of in this area, it has been studied and shown to be successful. So it is very squarely in our evidence-based practice kind of basket. So I wanted to just pause for a minute and say, like, I think for all of us who get into the helping professions, we want to help. We want to help. Like, I don't know, you were probably all kids like me, like super close to animals, like the person in my family who was like the peacemaker. Probably all your friends come to you for advice, and like we're those people a lot of times. So the reason that I just share this for a moment is, in some ways, motivational interviewing seems like it should be so easy for all of us. And I'm not coming to you as an expert today. I'm coming to you as a fellow practitioner. Like, I'm always practicing, it's just not as easy as it sounds. And I've really come to believe that a lot of it is because most of us were raised with our parents trying to get us to do stuff by using fear and shame and punishment because they loved us. It was like their motives were good. But I have a 13-year-old who's super into graffiti. He loves graffiti. He idolizes graffiti. He loves the illegality of it. These are pictures of him because I'm trying to like track him on the legal part of it. I took him to a legal wall. I want him talking to people who do street, I want him to get off graffiti and into like street art. Like, scares the bejesus out of me that this kid is like, enthralled with the illegality of graffiti. He's also adopted and his bio father had schizophrenia. So if this kid uses cannabis before the age of 15, his chances of actually awakening, of having schizophrenic symptoms are like tripled. And so my fear about this kid, I don't want any of my kids using, alcohol or other substances, of course, but my fear around this kid is much, much bigger. And as a result, like my communication with him around this stuff is much more unskillful. It's like, and so I'm like, right now I'm kind of asking you all to reflect. If you think about when you were a kid, like how did your parents try to get you to do or not do stuff? And, there's like fear. Oh, Tina. Love that message. Private message about my son. That's awesome. Thank you. I guess I would ask, like, if you can kind of reflect yourselves on your own, parents and maybe just chat in, like, where was their tendency? Was it about trying to scare you? Was it about like punishment, like super authoritarian? My family was super shame based. There was a lot of like, I never thought you would do that to me. I thought you were better than that. We're not mad. We're so disappointed. Don't you think like that's a lot of like shame based stuff? And the reason I ask that, yeah, Lauren says shame and guilt based. Yeah, that is me too. Shame and guilt. And I almost used to wish for punishment. I was like, God, how about just punishment and not like the shame or guilt? So I appreciate it. Yeah, if anybody else wants to just chat in, because often the trifecta, Sally said the trifecta, often what happens is however we were raised, like when we're really scared about that client or patient in front of us, or when we're really scared about that kid, like I am about my son, we kind of revert to however we were raised. We revert to like wanting to like scare somebody, intimidation with just one look. Yeah, fear. So I feel like for me, it's been just really worthwhile to reflect on that because when push comes to shove, we'll sort of revert to that often. So when I said MI was an empathy-based approach, I'm going to talk for about 15 minutes today just about empathy and how we communicate with our clients and patients that we're trying to help, because there are other strategies in MI, which most of you know, but none of them actually work unless the person in front of us feels like we care about them. None of them work unless our patient or client feels like we care about them. We cannot even influence the people we supervise unless they feel like we care about them. So empathy itself is the foundation, and empathy all by itself is healing, and judgment, which could also be like stigma and bias, is the opposite of empathy. So if we think about like a teeter-totter, empathy's over here. The more empathy we feel for someone, the less we feel judgmental. And the more we're judging someone or stigmatizing someone, the less our empathy is. So there's this kind of teeter-totter going on. And in the substance use disorder field, it is particularly important. I mean, all of you are in this field. You're all at this meeting. You're all working on OUD in your larger community and trying to save lives. And so, I'm sure you talk extensively about stigma. Stigma is the same as judgment. It's just a cluster of negative beliefs that we have about conditions or people. And I just wanted everyone to know, in case you're feeling this and you weren't sure, while stigma for mental health conditions has been going down for the last decade, stigma for addictive disorders has actually been increasing steadily for about 15 years. And that comes from a meta-analysis that was done, a public health meta-analysis that was done on stigma around mental health and addictive disorders that is also in that bibliography that I just shared. But we are, all of us who know what a big deal this is and know that stigma is actually harmful and that stigma keeps people from getting help, and that if people feel judgment like if we leak judgment in our faces, if we leak judgment in what we say, that our chances to help them just go out the window. It's just important to know that it is increasing. So what we're doing with our clients and patients and organizations right now could not be more important. I wanted to zero in on Jean Morrison, my mom, because empathy is healing and judgment is harmful. Like, often I'm talking to helping professionals and I'm like, why do we even need to talk about empathy? Because we all have so much empathy. And that's why we got into the field. So why do we even need to talk about it? And Jean Morrison is my example for this. Because my mom totally loves me. Of course, she's my mom. She totally loves me. She loves my kids. And when I talk to her, she does not respond in a way that feels empathic. If I share a problem with my mom, she'll say, well, what did you expect? If my son shares something with my mom about, like, come look at my room, I clean my room, she'll say, I don't know why you can't keep it like this all the time. So I'm sure all of you recognize Jean. You probably have someone in your family just like this. And I kind of laugh about it because she's got a really good heart, but there are real consequences to it, which is I'm not that close to her emotionally. I just don't talk to her because it doesn't feel good when I talk to her. My son actually doesn't even like to go to her house. He says all the time, she's always judging me. All she does is judge me. So he doesn't even want to go over to her house. And so the reason I share this is what we have in our hearts for patients and the people we work with at our organizations. You probably can think of employees like this, counselors, physicians like this, that have such a good heart, so much empathy, and yet what comes out of their mouth actually doesn't match. And so the patients don't feel it. And in fact, the patients might even feel judged. And then that causes harm. So that's really why we talk about it when we talk about motivational interviewing. It's not just about what we feel, it's about how we communicate it. How can we communicate it in a way that's really skillful? So before we jump to that, I really wanted to ask everyone this question, these two questions. What do you know about yourself? When someone is trying to get you to change, what works? And what doesn't work? And so I don't know if you've used Mentimeter before, but if you use your phone and just capture this QR code with your phone on the screen, it'll take you, I'll move the screen, but you can type in about as much as you want. It's totally anonymous, just so you know. But then we can see everybody's, like, we can see other people's responses. So what do you know about yourself? What doesn't work when someone wants to get you to do something or wants to get you to change, and what does work? So I'm going to leave this screen, but I can bring the QR code back up. I just want to bring up this screen so we can see what people chat in. So I'll just go back to this if people can capture this with their phone, just in case you didn't get a chance. And it'll take you to a screen where you can chat in. You can also just go to menti.com if you want, if that's easier on your phone, and put in this code. I kind of like the QR codes. So the first question, I can see people have already, let me just ask Lindsay, because sometimes that my screen doesn't show. Is the Menti screen showing, Lindsay?
Yes, it's working.
Okay, so great. So you can see arguing, shame, speaking down, anger. Yes. Yes, when I feel like I have to, like when somebody is kind of threatening your autonomy, like pushing you, like you have to. Shame, fear. Nagging, I see a couple people constantly bringing it up or nagging. Absolutely. Don't feel appreciated. Yes, when someone doesn't see like the good stuff. Yeah, feeling criticized, shaming. Should messages are shaming messages. Even when we talk to ourselves, if we should ourselves, we're shaming ourselves. Talking down to me, yeah. Like almost patronizing, like if you would just do this. Like I love it when people say, like, if you would just eat differently, as if changing food habits isn't literally the hardest thing on the planet. Fear, shaming, judgment, focusing on the negative. I like to address with respect on an intelligent level. Yes. I like to be given the facts. Telling, not asking. Yes. I so relate to all of these. Fear and threats, being dishonest. Yeah. I'm going to go to the next one about like what does work. And some of you did write what does work. Like I saw some things like gentleness, kindness, appreciation, um, people seeing the positive. I did see some of that on there, but I'll just give you a minute on this one. Oh, that's funny. When my vacation is approved. Yes. Asking me what I want. Yes. It's a primary motivational interviewing strategy is to ask someone, what do they want? Talking back and forth, like having a conversation, praise. That's actually the next thing we're going to talk about. Understanding and support. Understanding the why. Yes, getting real information. Compassion, constructive criticism, communicating maturely. Dignity, I love that word. Respect for humanity and dignity. Honest and open communication. Yes. Support, understanding me. Making me self-reflect. Yes. Asking the self, asking us. Yeah, feeling understanding and compassionate, about any resistance that we have to change. This is so great, dialogue versus being told. I so appreciate all of you being willing to do that. Because as many of you know who are 3s and 4s on the motivational interviewing, like how much you're knew about it. There's so many motivational interviewing strategies. And, we had 50 minutes today. So I just picked 3. And on those answers that you gave, you covered all 3. So I'm so glad. So many, many, many of you wrote empathy, whether it was compassion, kindness, respect, feeling appreciated, dignity. These are all words that I would say are empathy, feeling like somebody cares, somebody is respectful, someone sees you as an equal human being. And that is exactly why empathy is the foundation of motivational interviewing, because we have absolutely no influence on somebody, no hope to help them change for the good if they don't feel that from us. So I just wanted to share some really fascinating research about empathy, which is empathy seems to work biologically. When people feel empathy from us and when we feel empathy from others, our wounds heal faster. So a lot of research around wound care and empathy. And it's also why when your kids get hurt and you show all this empathy, it's also why they stop crying, and we'll talk about it actually helps with pain. But there is a good amount of research that shows that when our clients and patients feel empathy from us, not just physicians or therapists, but the whole healthcare, the whole team, that they can relax. Their stress hormones can relax. And so their immune systems work better. It increases adherence because if we feel like somebody cares about us, we're more apt to do what they recommend. And it increases self-disclosures because if we feel like people care about us, we're more apt to share more with them so they have more information, so they have a more accurate idea of what we're even struggling with. In fact, empathy is correlated to accurate diagnoses in mental health and in medical care. Just super specific research that I'm a total nerd about, and I'm not going to belabor, but is so interesting. And like I said, there's a hyperlink to this at the end, but there's research that shows that when people come into our systems and they are met with empathy, that the symptoms of the common cold that they might have are actually less in duration and less in severity. So with no other treatment in medical and social care settings, if people have a cold and they're met with empathy, they'll have symptoms for a shorter duration and less severity. Because the highest stigma conditions in primary care are pain, chronic pain, and addictive disorders. And a lot of it's because of the Venn diagram overlap of those two conditions. There's evidence that shows that when people feel empathy from us, their self-reported pain levels go down. It's also why when people feel judged about their pain, that they will actually ratchet up their disclosures of pain. If we're not feeling compassion for them, we'll say they're just exaggerating to get pain pills. There's actually real evidence that shows they actually are feeling more pain when they feel judged. And then, of course, in substance use disorders, which we'll talk about more next. But there's also research that shows that empathy all by itself is a treatment for anxiety, diabetes, and depression. I think the diabetes research is most fascinating, which is it shows that when a patient feels from empathy from the healthcare team, their A1Cs are lower, which is the blood sugar measurement, lowers better. And when they feel judgment, actually, it's higher. So the opposite is also true for all of these. We talked about that teeter-totter of empathy and stigma and judgment. But when I share that empathy is helpful with all of these things, judgment is actually harmful. In fact, I'll tell you in SUD, there's a really interesting study called Toxic Therapists. And it shows that when therapists leak out any judgment at all about the patients that they're treating for alcohol use disorders, those patients drink more. So really, I don't know, kind of scary and sad. So I just want to stop there and invite, Rebecca just chatted in. I wanted to invite people to chat in just a little bit about that before we go on to these strategies. Yeah, Rebecca, I'm surprised stigma is going up with all the work and light we've been shedding on this. I am too. And one of the things that I wonder about is because there's always a lag time on research. I wonder if we will see the fruits of the stigma work that in particular has been done around medication assisted treatment and opioid use disorder. I wonder if we'll see the fruits of that in the coming years on the research. That's possible. I feel like I thrive when people doubt me. Yeah, Lynn. So you might have that like sort of prove you wrong, fire in you. Yeah. Others? You can take yourself off of mute too if you just want to say something, but I'm just curious if people have other responses to the empathy research. All right. Well, please don't hold on to it if you do. Just please chat in. I wanted to just switch and talk about these three strategies. Like I said, I mean, there's so many to choose from. But I chose these three. And like I said, I would love it if you would chat in, like if this is what you use. Because I suspect a ton of you are using open-ended questions all the time. Open-ended questions were actually called by, are called the gold standard of communication. And that's in medical settings, and that's in mental health settings, and that's in substance use settings. How? Yeah, Sally said, so open-ended questions, of course, start with how or what or tell me more. Tell me more isn't technically a question, but it acts as a question. Tell me more about that. Um, ah, oh, that's so great. I love that. Thank you, Grant. That's awesome. So these are closed questions. The first one is what I call a narrow question. If you say to somebody, where does it hurt? If you say to somebody, how many siblings do you have? If you say to somebody, what drugs are you using? If you say to someone, what medicines are you on? That's not a yes or no question. It's not closed, but it's so narrow that it doesn't convey empathy because it doesn't say to somebody, I really want to hear anything you have to say. I really care about your thoughts. And it doesn't allow them to go anywhere they want. You've kind of boxed them in, right here. So these are all questions that we don't get rich assessment information. Open-ended questions are actually correlated with accurate diagnoses as well in medical and mental health and substance use settings because we get so much richer information. But importantly, for the reason I'm sharing it today is many of you wrote, what helps you change is when people ask you. So instead of asking these, right, we can say to people, thank you so much for sharing about your cannabis use. Tell me more about that, right? Yeah, tell me, it sounds like you made a decision to stop the Suboxone and to go back to using cannabis. Thank you for sharing that with me. Tell me more about how you made that decision, right? So everyone feels differently about their, smoking, about their nicotine use. And so I just wanted to ask you, like, what are your feelings and thoughts about your nicotine use, right? Why, how, tell me more. What does this look like for you is a lovely question. Love that question. Why is the stem of an open-ended question? The problem with it is it sounds so judgmental. Like 15 years ago, I weeded why out of my vocabulary. I don't even say it to my kids anymore. I just like in my mind, I have a big like slash through it. I mean, if you ask your kids, why did you do that? You're never going to get good information. I mean, they feel like you're judging them. They can't tell you what's, true. And so, why did you stop taking your medicine? Why did you relapse? Why did you, why do you use? What emotions have you been feeling recently? I love that. Love that. Super open, like beautiful. The second one is empathic reflection. We used to call it reflective listening, but I think a lot of people have had bad experiences with reflective listening. I mean, when I call like the Sears repair people and because my dishwasher's broken again and they won't replace it and they keep coming out and fixing it and they say, I'm so sorry to hear your dishwasher's broken again. I know they're scripted. I know they have to say that and it makes me mad because I don't think they're getting paid enough. I think scripts are terrible for employees because it like squashes their autonomy and it doesn't do what it's supposed to do. It doesn't make me feel cared about. But skillful empathic reflection, when somebody says, I don't know why I keep going back. I don't know why I keep going back, to using. And instead of, trying to answer that for them, we just say to them, yeah, it sounds like you don't know. You don't know why you keep going back. And we just reflect back. It just gives people so much space to answer and continue and share what they want. Why did you relapse is the silliest question. It's literally like asking your kids, why did you do that? No one, I mean, I'm a recovering person. I'm guessing there's lots of recovering people here in the room. Like when we relapse, we don't even know why we relapse. It's like asking somebody why they use. You kind of make up a reason if someone's asking you that because you think you need to have a reason. But it would be probably accurate to say I use because I have an addictive disorder. I relapse because I have an addictive disorder. So these are, I'd love to hear how many people regularly use empathic reflection. Sometimes people are a little scared of it because we're afraid people will know we're repeating and be mad at us. There's a lot of research specifically on empathic reflection though, and I use it all the time. I'm using it right now where I'm repeating what you said in the chat. So that I heard you and I'm not doing it purposely to be manipulative, but I really do it naturally, sometimes better, sometimes less. But summaries are really helpful. When someone talks for a long time, 2 or 3 minutes straight, you can say, gosh, thanks. It sounds like it's been a really tough year for you. When people repeat things, when they're mad and they say to us, I'm just so sick of this place. I wait forever every time I come in. I've had it. I'm so sick of this place. We can say, I totally hear you. I would be frustrated too. Sounds like you're just sick of us here, sick of the wait. Using some of people's exact words. And then double-sided is when, people share that yeah, of course they want to quit. And now doesn't feel like the time for them to go into treatment. They share kind of both sides of that ambivalence with us that we just share back. Gosh, on one hand, you feel like this. And on the other hand, you feel like this. So there are lots and lots of ways to use reflection. Oh, Kimberly. Yeah, Kimberly says all the time. There's entire counseling methods that are based just on reflective listening. It is the only thing that you do when you're with someone is you reflect. It still takes a lot of skill because you have to decide what to reflect because you don't reflect everything that's said. So you reflect some things and then that guides the conversation and then you reflect and then you reflect. It's so effective. It can be used by itself. It's really strong. So Lindsay, the answer to that question is yes. So the third thing is affirming strengths. And when you all were answering what works for you, a lot of you were writing this. A lot of you were saying, when I feel appreciated, basically when someone can see the good in you, that even if you're talking about something you struggle with, or even if someone's talking to you about something you struggle with, when they see you as a whole person, that they see you the good in you too, it is so powerful. And it's one of the reasons why it's one of the prime strategies for motivational interviewing. So affirming strengths is when, if someone shares with us extensively why they're not going to get vaccinated or extensively why they're never going to quit drinking, and they've done, maybe they're sharing with us how much they've thought about this or what they've tried in the past, just to see that as a strength and say back to them, gosh, you've given this a lot of thought. Or gosh, you've researched this a lot, or I can tell how important this is to you. No matter what someone is sharing with me, no matter how much it seems like they're struggling, to look for the good, put on our strengths glasses, look for the good, and share it back with them. I do a lot of therapy with women who are using during their pregnancy because I see a lot of staff and A lot of their PCPs refer them to me when their labs come up with positive for substances. And a lot of times I'll just say to them, hey, tell me about that. Like, thank you for so much for being willing to see me and talk to me about this. Like, I'm guessing it was really hard even to come that your PCP referred you, and tell me about it. And sometimes they'll say extensively why they're smoking pot because I think it's better for their baby than the stress they're feeling. And I'll just say to them, gosh, you really care about your baby. Like, you're really trying to do right by your baby. And of course, we're going to talk about later, about the fact that that's not totally accurate, that pot is better for the baby than stress. But I just want them to know I see that you really care about your baby. So super powerful. So what I wanted to do now, and I'm hoping there is a lot of you who are up for doing this, because I just feel like we don't always get a lot of time to talk to our colleagues. And when we ask an open-ended question, when we use reflective, like empathic reflection, and when we affirm strengths, it actually feels really good. And so I just wanted to give all of us a chance to do that with each other, not role playing, just as yourselves. So what Lindsay's going to do is divide people up just into pairs. And so the first thing that you'll do is we're just going to do 6 minutes. So it's really short. And you'll decide who's going to practice open-ended questions, reflection, and strengths, and who's going to share first. And if you're the person who is practicing, the first thing you'll do is ask an open-ended question of your partner. You'll just say, hey, tell me about something that you feel comfortable sharing about that's troubling you right now. And when you're the person who's sharing, pick something real. Like if Lindsay asked me right now, I would probably pick my son because I know her and I would feel comfortable sharing. If I was with one of you that I'd never met before, I might pick something less vulnerable. I might pick the fact that I'm really struggling with sleep lately. So ratchet up your vulnerability up and down in just how you feel comfortable. Share with your partner just for a minute or two. And then when your partner shares back, they're going to reflect what you said. Gosh, I hear. And they're going to share back what they see as your strengths. So no problem, Connie. Thanks for letting us know. The most important thing when we're practicing, the most important thing is don't role play. You're just having a conversation with a colleague. And the second most important thing is no matter what, don't give any advice. None. Just reflect back and share the strength that you saw in them. So Lindsay would probably share back with me about my son something like, gosh, you think about him all the time. You think about how to interact and be helpful to him all the time, which is true. I do. And I would love for somebody to reflect that back to me because it makes me feel less hopeless and at odds with myself as a mom. So that's what we're going to do. So I'm going to stop there and I will let Lindsay, and when it's been 3 minutes, Lindsay will send a little note to you that it's time to switch with your partner so that you both have a chance. And then we'll see you back in about 6 minutes. Okay.
You had a ton of people log off the minute you said there were going to be breakout rooms.
That's why I always want to give people a chance to not be in them.
Yeah, I'm just monitoring. It looks like Michelle's in one by herself.
I'm sorry, I was one of the people. I got to take off too. So I was just typing that in and then you said that and then I felt guilty, but I do have to take off because it's 3 and I gotta go. I gotta run. But I loved your talk so much and maybe I can see you again on here or something.
I hope so. Thank you so much, Rebecca. No problem. Have a great afternoon.
Thank you.
All right, I'm moving people around to make sure that everybody has something.
I wasn't assigned to a room, right, Lindsay? I'm just making sure.
No, I didn't assign you, but
fine.
Paul, Doug, and Aegis, I did assign them. So they're in with somebody by themselves that hasn't joined.
It's always the calculus of workshops.
All right, so
do you just talk to people?
that they went where they're supposed to. Hold on. So Doug, oh, Tina's by herself, so I will move. Okay.
And Paul looks like he's by himself. I could join him if we need another person.
Now I'm gonna move people around. I just gotta find where there's one.
Yeah, Paul is room 15.
There's two people in there. Oh, okay. I moved him.
Okay.
I moved Tina.
Yeah,
Probably
the
really confused.
Aegis didn't join, so.
Okay, and then Doug didn't join. That's okay. All right, so where did I put? Okay, so we're okay.
Yeah.
Paul and Tina in a room together. Doug is still out.
Cool. Thank you.
All right.
And Lindsay, if you can chat into the breakout rooms if you can write, and I'll tell you when to send it. It's about 30 seconds just to say it's time to switch.
Okay, let me know.
Okay.
By the way, I'm getting a ton of great feedback.
Oh, good.
Yeah.
Well, man, I feel like it's so
Getting
much
text
about
messages.
just like engaging,
Yeah.
Yeah. And it's so great. I love seeing people chat. I'm so glad. You never know if people will
Mhm.
interact with you, but it's great. Okay, you can go ahead and send it.
Okay.
And then I'll reset the timer.
Lindsay, for the Survey Monkey, do you want me to send you that link?
No, I have it in my notes here, and I'll just have you do it when I bring it up later on. I'm just bummed that we lost so many people.
I know. It's good feedback because I try not to do MI without practice.
Yeah.
Because it doesn't change practice behaviors without practice. But if you lose a lot of people, then it's like,
It is what it is. But,
Yeah.
and I expect doctors to absolutely log off because they
Yeah.
they need this. They need this for sure. So
Can I check on the time? I thought it was till 3:10 that I had. Is that still right? Or is it?
yeah, if you need more time, that's fine, because I think our unfortunately our personal story speaker kind of hard to get a hold of. So you have a few more minutes if you need it.
Okay. Okay.
Yeah.
So you can, let's see, is there a 60-second delay on the closing of the rooms?
Yeah, I think that's what I have it set for. Let me
Okay.
check. Hold on.
So I'll tell you when to close them. And then what you can chat to people is if you want to use that minute, that delay, feel free. We don't.
Let me know when to close them.
Okay. So it's about 20 seconds till we close them.
Are you going to go a little bit into talking to pregnant women too in this one?
I have examples around pregnant women.
Okay, good.
Okay. Yeah. Okay, you can close them now and just tell them come back or use the time. Either one's fine.
All right. Usually my right hand does this for me, Sam, so I'm proud of myself for not messing it up.
Yeah, you did. That was awesome. Hi, I see people coming back. Hi. Um, I think we have still some people in breakout rooms, right, who haven't come back. So I'll just start slow talking to you all just to say, as soon as we went to breakout rooms, Lindsay said, "Oh, you lost a bunch of people." I just want to acknowledge, it's always a hard decision, I always feel like it's important to practice MI when we're talking about it. And yet, we don't want to lose people. So I just wanted to say thank you all so much who stayed to practice, because I know it's more vulnerable and I appreciate it. And we're totally open to feedback, Lindsay and I, about whether it might be better, not to do breakouts in a format like this. So welcome back, everybody. Thank you so much for being willing to do that. I know breakouts for people are often kind of mixed, and I really hope you had I don't know, a couple minutes of getting some really high quality listening from your colleague, because it always feels really good. I do a lot of training of therapists and counselors, and we do 2-hour seminars on Fridays, and 1 hour of it is fully just us practicing with each other, with ourselves. So we always get like a lot of therapy too. I wanted to just switch for our last few minutes and talk about, part of what we're doing is these, talk about these two kind of axes of change. So if we think about a woman who is pregnant and using substances, there's like if you think about a 0 to 10 scale of importance, how important does she feel like it is to stop? Right? There are some people whose importance is very low. When importance is very low, it feels like denial, right? Like it's not important to stop. They don't want to stop. That's like low importance. Then there are people who are like pretty high. They're like an 8 or a 9, where they're like, yeah, it's important to stop, but I've tried treatment, or I can't do it, or I've tried Suboxone, And that is not an importance problem. That's a confidence problem. They want to do it, but they're not confident they can successfully do it. Or they've had like failures in the past or relapses in the past, so their confidence is really low. And as you can see from this grid, people need to be in that top right quadrant with pretty high on both to actually make a change. So what I want to talk about before we end today is, I think we're most of us are really good at increasing confidence. Like if someone wants to quit and their confidence is low, we're like, wow, do we have resources for you? Like you can see a counselor, we've got BUP, we've got we've got a case manager, like we have all kinds of things to help you. What is trickier is when we're interacting with people whose importance is low. When we're like, so I just got your labs back, and there's, opioids in your labs, and please tell me, like, fill me in about that. And they say, well, I can't sleep, I've got pain, and you can just hear they're not in the place where they're thinking about treatment, where they're wanting to quit. So I wanted to just talk about some of the top strategies for really jumping in with that. As you all pointed out in the What Works for Me Mentimeter that we did, really what we want to do is elicit like their motivation, their own motivation. So in importance, even when someone feels like they're totally in denial, nobody is ever a 0. Nobody wants, in fact, there's March of Dimes. I used to do a lot of work with the March of Dimes for perinatal substance use. And there's a ton of research that shows that it's like 97.8% of women or something like that, think using substances while they're pregnant is harmful or, bad. And so it's like this fraction of a percent that really truly are in what we would call complete denial. And so what we really want to do when someone seems kind of low in that is to say, tell me more about that. It sounds like you thought a lot about this. It sounds like you feel like, you wouldn't be able to tolerate your pain, that you wouldn't be able to sleep, that your withdrawals, if you went through withdrawals while you were pregnant, which is what a lot of women say to me, you're afraid it would harm your baby. Like, tell me more about that. You really want to invite to get people talking about this, because otherwise there's no way to sort of move around and help in that. The second one is that double-sided reflection. Because if somebody says, well, of course I want to stop, but I do not want to go through withdrawals when I'm pregnant. If we say back to them, oh, we've got stuff to help with withdrawals while you're pregnant. If we just reflect that back, then the other side of the teeter-totter comes up where they're like, no, I don't want to do it while I'm pregnant. So we have to reflect back both, right? Where we say like, oh, it sounds like there's a part of you that really, really doesn't, wants to stop. And there's this other part of you that's really afraid about withdrawals, right? That like double-sided reflection. And then eliciting, this is like just one strategy. Would love to hear about how people word this if you're using this consistently, which is eliciting the good about not changing. So to say to somebody, well, tell me about what opioids help you with. Tell me about what does cannabis do for you? What's really helpful about it? Yeah, tell me about smoking. What's it useful for? What are the good stuff? I know there's good stuff. just to like really show yourself like you are comfortable with this, you are willing to hear the good stuff. It's only when we really like let people know, I understand, we hear you, I get that often we don't even have to say, what's the other side of it? Often as someone's telling us all the good stuff, they'll say, but I know it's not good and I really don't want to do it. And my boyfriend's super mad at me all the time about it. And like often they'll immediately go into the downsides. And that's always where we want to be in motivational interviewing. We want to be helping clients talk about changing. This is one of the things, again, back to what you all sort of, I don't know, like said, what helps you is to always be saying to people, it's your choice. This is affirming autonomy. It's scary to say this because sometimes we want to say to people, you have to, you need to, you must. And psychological autonomy, we all have it. As soon as you say have to, need to, must to me, I'm like pushing back on you. We all are. And so anytime we want to say that, to like really like take a deep breath and say, totally your call, totally your decision, totally up to you. I used to work with a physician who would always say, you're the boss. You're the boss. You're the boss. It's your body. It's your decision. Like saying this over and over is actually an MI strategy because it helps people come closer to us instead of pushing away. We're going to sort of end on this quickly because you all said these things, but I always say I'll end with three things, like avoid at all costs if you can. And like I said, I end up doing this. We all end up doing these things as parents, as friends, as practitioners. But the shame piece, the shame separates. Anytime we say should, or you need to think about your kids, or you need to think about your baby, or those things, people don't want to come back and see us. Or if they do, they won't tell us the truth. It separates us. Yes, but like arguing and then cornering people. Don't you think you should? You really need to. All of these things are really push people away from us. I just wanted to end with this and give Lindsay a few minutes to close up the meeting, which is my website where there's like a bunch of, and I know SSVMS has a website with a bunch of free resources too. I just wanted to share there's a bunch of free MI resources on there. My email in case anybody wants to chat with me afterwards, and then a hyperlink to the research that I talked about today. But I really wanted to thank you all for being willing to break out and just for being here today and for all the work that you're doing on this coalition. So thank you.
So before we let Elizabeth go, does anybody have any questions for her? We have just a couple of minutes before we have to move on. Well, I really enjoyed your presentation and was slightly laughing to myself that I could use these techniques with my son. And besides the work that we all do here. So yes, I definitely took something away from today for my personal life, at least for sure. So thank you again. And we will be sharing your slides with everybody here after the meeting. Wonderful. Thank you.
Bye, everybody.
Okay, so we have just a couple more things before we end today. I wanted to bring everybody's attention to the fact that we are doing a survey. Lauren's going to drop the link in the chat for you on how we're doing as an opioid coalition. We're really trying to improve what we're offering to the community, and the first 50 people that answer get a cup of coffee on us from Starbucks. We'll send you a gift card, an emailed gift card. So I'd really appreciate your feedback, though. The executive committee is really trying to make some changes and make sure that these meetings are worth it for all of you. So with that in mind, I'm actually going to start the last portion. This is something we're going to do at every meeting where we just call on a few people randomly and ask, who is your organization? What type of work do you do? And how do you help the community, or how do you work in opioids? And I'm going to put all these questions in the chat here for you so you can reference it. But first, I'm actually going to call on Michelle Best because she's going to share, but she's also going to share a little bit about a program she's working on. So Michelle.
Okay, perfect. My name is Michelle Bessie. I'm a program planner with Sacramento County Substance Use Prevention and Treatment Services. Gosh, we do a lot on opiates, from treatment, all levels of care, residential, withdrawal management. We work with the SURE program. We have outpatient and intensive outpatient. We have prevention services. We have a lot. We have a Narcan distribution project and a number of different initiatives going. One of the ones I wanted to talk a little bit about today was the Sac County Healthy Beginnings one, working with prenatal substance exposure and working with women who are pregnant and using, and then also working with moms who have had children who are prenatally substance exposed and really educating the community on the topics around prenatal substance exposure. So I have dropped in the chat our training flyer. All trainings are free for any provider in Sacramento County. Comes with all the resources. We also have our website with lots of training tools and resources and a toolkit for providers and for families as well. So please check that out.
Awesome. Thank you, Michelle. And the link is also in the chat for you. All right. So I'm just going to randomly, actually, does anybody want to raise their hand to go? I probably should do that. Any volunteers? Yes, Ashley, please.
Hey, so my name is Ashley. I'm with Treatment Associates, and we are a outpatient MAT program. So I think the way that we help the community is by dispensing medication to patients who are suffering from opioid use disorder. I think I'm kind of starting to get my feet wet with like community outreach things. You know, I've been with Treatment Associates for about 2 years. And so I'm just finally starting to get fully comfortable. So I hope that we as a treatment provider can do more with the county and the community, you know, in the upcoming months.
Perfect. Thank you, Ashley. Grant, yes.
Hang on, let me put my hand down. Thank you. Thanks so much for having me. It's my first meeting. I am Grant Boykin. I'm with an organization called Shatterproof. It's actually a national nonprofit that was started when our CEO lost a son to opioid use disorder about 10 years ago. But we work on advocacy, education, and awareness around all substance use disorders. And one of the things that we're doing, we've done it in 12 states already. California is our next one, is a free online substance use disorder treatment locator. So coming in the spring of 2023, all treatment providers who are licensed in California will be on the site. And we're trying to make a big push for them to give information to us. We're actually in the state budget. Department of Healthcare Services has been a big partner of ours. And we just met with the County Behavioral Health Directors Association last week. So I'm based in Sacramento. The organization's based in Connecticut, but I'm trying to get a feel of the landscape here. So this meeting popped up and I thought I really wanted to come and learn from all of you and see what's going on. So thanks for having me.
Wonderful. Welcome, Grant. Glad to have you here. And your organization is definitely is needed in our area. And I saw in the chat that Lori has a meeting with you later this week. So great. I'm glad you're connected and you're able to make it today.
Thank you.
If anybody else on the Opioid Coalition is interested in joining our meeting, feel free to do that. I can forward the invite if you email me at Miller, MILLERLORI @saccounty.net, but the meeting is scheduled for Wednesday, the 20th at noon for an hour, 12 to 1.
Awesome. Thank you, Lori. I appreciate that. All right. Any other volunteers before I start evilly calling on you?
Lindsay, I'll go.
Perfect. Hi, Doug. Nice to see you.
Hiding in the shadows the whole meeting. I'm Doug Colbert. I'm the executive director for the California Product Stewardship Council. And you may wonder why are we involved? Well, I was a previous Sacramento County employee for 18 years, so I got involved in this coalition right at the beginning of it. Happy to be part of this wonderful group. And CPSC, or California Product Stewardship Council, sponsored the bill SB 212 that was passed in 2018 that required all pharmaceutical manufacturers to provide safe take back of unused and unwanted medications. So I just wanted to pop in and let folks know that that law has been in effect now, and full implementation of the program, meaning safe return bins, collection bins in many pharmacies across the state, should be fully implemented by September for one of the companies that's funding this and running the program, and the other one by December. So if you see don't see a collection bin in a pharmacy, it doesn't mean it's not supposed to be there. Maybe they want to be. Talk to the pharmacist, see if they want to be a collection site. It's not too hard to become DEA registrant. Janet Michelle has had her bin in there since the beginning of when CPSC started doing this. So she was one of our inceptors of getting this program going way back when, even before way before 2018. So anyway, if you have any questions, just feel free to reach out to me or reach out to Lindsay or Lori. They have my contact information. I'd be happy to help, because we definitely want to get out as many of the collection bins as possible throughout the state.
Awesome. Thanks, Doug. Nice to see you again. All right. Severin, you're up.
Yes, hello. My name is Severin Hollingsworth. I'm the community liaison for BART programs and MedMark Treatment Center. I'm actually Ashley's neighbor. We are right across the street to each other, working with many of the same patients. I'm going to echo, we need to keep talking about what we are doing, because what we are doing is very, very important. So that's why I like to attend the coalition, and I'm advocating in the background, we need to talk about it. Now, when I'm putting in the survey, like Rebecca Harris, I'm kind of concerned that the stigma is not going down. So I don't know, I think we need to focus on this as a community, because we really need to be able to have conversation about the opioid use disorder and opioid in general. Like if we were talking about diabetes, this is where we need to take it. So I'm with you, I'm cheering, and I love working with everybody. Thank you.
That's wonderful feedback. We really appreciate it. Keep that feedback coming so we can plan these meetings and make them worth your while. Grace, you have your hand raised. You're up.
Hey there, I'm Dr. Grace Tidwell. I'm the incoming Chief Medical Officer at Ellica Health Centers. So we're a federally qualified health center, and we offer primary care, but in addition, addiction medicine, including MAT, and we have a behavioral health program. We are going to be expanding our program, so we have lots of availability coming up. We take all insurances, and we have a sliding fee program for folks without insurance. So it's nice to hear what everyone's doing. This is a great group. I've been trying to attend for the last couple meetings like this, so thanks for putting this on.
Absolutely. Thank you, Dr. Tidwell. And I'm just so you know, the presentation today, there's 2 others in the series, and we're happy to come to Ellica and put them on for free and provide CME for you. So the same to anybody on here. If that's something you're interested in, I'm going to just drop my email here in the chat. Email me, and we'll get something on Elizabeth Morrison's calendar. And we also have a pharmacist that will come and do this as well.
That is fantastic. Thank you.
Thank you. All right. I'd say we have time for at least another 1 or 2 more volunteers. Any takers? Tina, I cannot believe you're not volunteering. What are you doing? Come on.
I'm withholding. I'm holding back.
Too bad.
All right, I'm Tina Reynolds. I'm the president of Uptown Studios, and we work on behavior change campaigns and social change campaigns. We do a lot of work with Lori Miller, and we've done We have done work with Lindsay Coate on both opioid and methamphetamines. And if you need help or advice on marketing, I am happy to give you some time and tell you some of the things that we have done and the things, how they're working, and social media, video, graphics, websites. If you can see it, we do it. And then we really are geared to changing behavior and building community. Thank you, Lindsay.
Thank you for letting me abuse you. All right. Kalita Dennis, would you like to go next?
Hi, my name is Kalita. I'm a student at Howard University, majoring in criminology and minoring in psychology. And just kind of wanted some more experience in the psychology field and see, what there is for me. So I'm volunteering for Lori Miller.
Fantastic. Glad you could make the meeting. Let's do just one more. So Melissa Visgar.
Hi, everyone. I'm Melissa Visgar. I'm with Sacramento County Substance Use Prevention and Treatment Services. I am one of the new program coordinators. So as far as services, I think Michelle Bessie did a really good recap of what services we're offering right now. This is my first meeting, so I'm really just interested in kind of understanding opioids and services in the community. And I also have worked with Lauren before on a lot of the flyers. So really just want to acknowledge Lauren for all her work and our outreach to the community. I mean, it's been a lot of, from what I've heard, resources. So just shout out to Lauren for everything that she's doing. Thank you.
Thank you for doing that, Melissa. As many shout outs for Lauren as we can get. That's the best thing. I think we're going to go ahead and end right there today. Thank you all again for joining us for today's meeting. Our last meeting of the year will be on October 17th, same time, same place on Zoom. And, depending on what kind of feedback we get from the survey, that will determine the types of speakers that we bring in for all of you. So thank you again. So nice to see all of your faces, and I look forward to seeing you all then.